MRD, or measurable residual disease, as we know, it's an up-and-coming biomarker that we are using not only in plasma cell disorders but across hematologic malignancies. Now, the role of measurable residual disease or minimal residual disease, however you want to call it, or MRD, is very clear in multiple myeloma, where we know that patients who achieve MRD negativity, they usually have better long-term outcomes in terms of progression-free survival and also overall survival compared to those who are MRD positive. But the data in AL amyloidosis has been less clear, given that the number of patients is not as much. So many of the retrospective cohort studies that have been reported from various institutions, they have not been able to show a statistically significant difference, maybe a trend towards better outcomes in MRD negative compared to MRD positive. And also the timing of the MRD assessment is critical, and that has been heterogeneous across studies in AL amyloidosis. So we recently published our finding from Columbia University, again a small patient cohort, roughly around 45 to 50 patients who had bone marrow minimal residual disease assessment. One of the strengths of our analysis was that the MRD assessment was done early, approximately at the end of 6 cycles of Dara-Cy-Body. More than 50% of patients in our cohort had received Dara-Cy-Body based frontline treatment, and the remaining received either bortezomib based, for example, Cy-Body, and some received autologous transplantation. So we had MRD assessment early, approximately at 6 months from diagnosis, which kind of correlates with when we clinically want that information. And we found that patients who were MRD negative, they had a trend towards higher incidence of cardiac organ response at the time of MRD assessment compared to those who were MRD positive. However, we also looked at data approximately 1 year out from the time of MRD assessment, and there we saw that even patients who were MRD positive, as long as they were in a deep hematologic response, many of them achieved really good organ response, the cardiac organ response, although there was still a numerical trend towards increased incidence of cardiac organ response in patients who were MRD negative, but it was not statistically significant. Perhaps our analysis was underpowered for that, but we clearly saw that a significant proportion of patients who were MRD positive also achieved good organ responses. Hence, I think it's very early to say, we don't have enough data to say that patients who are MRD positive in AL amyloidosis, we clearly have to give more treatment to flip them into MRD negative, because these patients are usually very frail, and many of the patients who are MRD positive can still go on to achieve good cardiac organ response. So we definitely need larger and more importantly prospective studies to make that recommendation whether we need to escalate treatment if somebody is MRD positive. Regarding renal response, we did not see a clear signal. We did not see a clear numerical or statistical trend for increased renal organ response among patients who are MRD negative compared to those who are MRD positive. Again, small patient numbers, so we definitely are looking forward to longer follow-up of our patients and more data from multi-institution collaborative studies.